Occasionally, despite blood tests showing that you have primary hyperparathyroidism, the scans might not pick up any abnormal parathyroid glands. When we are faced in this difficult situation, the next step depends on the clinical indication for surgery and what has already been done. The first port of call is to confirm the diagnosis by carefully going through the investigation so far, and then identifying whether any other scans are required or if they need to be repeated. Occasionally, we perform a special CT scan or a PET scan of the parathyroid glands. However, we can occasionally be faced in a difficult situation where scans have not been helpful and surgery cannot wait due to the risks of high calcium levels in the blood. In this case, we need to perform what is termed as a neck exploration or a cervical exploration. This requires us to carefully dissect out each of the 4 parathyroid glands and make a clinical judgment on which glands to remove based on their appearance. Sometimes it's not just one, but all 4 of the parathyroid glands that are overactive. This is a true Goldilocks moment where surgery needs to be just right. Removing just enough parathyroid tissue, but not too much. This makes the difference between undertreatment and overtreatment. Undertreatment means that you are not cured of the hyperparathyroidism, and this can lead to redo surgery, which is always difficult. Therefore, we want to get this right the first time. Overtreatment means that you are at risk of having too little parathyroid hormone after the surgery. Again, something that parathyroid surgeons really want to avoid. When embarking on surgery, it is important to understand that parathyroid surgery does come with the risk of either under or overtreatment. Every surgeon goes through a journey of making sense of this balance, and there isn't always a straightforward answer. The challenge and the joy of parathyroid surgery is not only how technical the operation is, but also the very tricky decision-making process in the lead up to surgery and during surgery. Let's go through an example of a difficult case in this 30-year-old gentleman. He presented to me with dangerously high calcium levels in the blood and unable to tolerate the tablets that would bring this down. None of the scans found an abnormal parathyroid gland. Surgery could not wait, and we needed to proceed with surgery to look at all 4 parathyroid glands. During surgery, we found that all 4 of the parathyroid glands were larger than they should be. A normal parathyroid gland is the size of a lentil, and in this particular case, they were all enlarged, with the largest being about the size of a kidney bean attached onto the thyroid gland. We removed 3 out of the 4 glands and half the thyroid gland, leaving him with a single functioning parathyroid gland. This clearly meant that after the operation, we needed to pay careful attention to his calcium levels. This is not an easy task, as we want the calcium to be high enough so that he did not have any symptoms, but also low enough to allow the remaining parathyroid gland to kick into action. This required careful monitoring of both symptoms and calcium levels in the blood after surgery, but also good communication with both the patient and my endocrinology physician colleagues.